Our next talk is from Samantha Gelfand on Kidney Pal, our prize program in kidney-related palliative care. Sam did her med school in New York at Mount Sinai, residency at Yale, renal fellowship at Penn, and then came to do a palliative care fellowship at the Brigham and Dana-Farber that finished in 2020. And she's been on staff both as a palliative care physician and very highly active in their training program at the Farber and as a nephrologist. And we're very proud of the Kidney Pal program, which she's going to talk about today. She's also an expert on conservative kidney management and kidney supportive care, which I'm sure she'll talk about. But we become addicted to this kind of a support, and it's been a really wonderful service that has worked extraordinarily well. So happy to have her give our keynote talk on kidney palliative care.
Thank you so much, David. Thanks for having me and for highlighting this aspect of nephrology. All right, so you just heard about my bio. I did nephrology first, then palliative care, and I have no disclosures. Today, I plan to describe the utility and scope of palliative care across nephrology, and then spend some time reviewing what conservative kidney management is and why I believe it's a valid alternative to dialysis for some older and seriously ill patients. So, basic stuff here. Kidney palliative care, also known as kidney supportive care, is care aimed at quality of life. It's trying to help people and their families live as well as possible with their advanced kidney disease. We do that through managing symptoms and giving support as people navigate complex decisions. And of note, it's important to say it can be applicable at any age and any treatment modality, any age, any stage, as they say in CAPC, the Center for Advancing Palliative Care. This image on the left that shows the slowly increasing red triangle here depicting kidney palliative care relevance in most people's care over time is the best way to think about it, as a concurrent longitudinal area of your own practice. Even as a general nephrologist, as time goes on, patients get older and they get more complex, and it's more and more common to have kidney palliative care issues like severe symptoms or hard decisions rise and become more prevalent. I think the image on the right is to remind us that we really don't talk or think about it anymore as it's time to transition to palliative care. That language comes from hospice, the unfortunate situation of hospice in the US, which is that you have to stop other kinds of care in order to enroll in hospice. That's not true of palliative care. Palliative care is something that nephrologists can be practicing as primary palliative care alongside their CKD care, and specialty palliative care like my team can be involved very early on. People who are in their 30s, people who are awaiting transplants, people who want to do home dialysis. Like we have patients across the spectrum of disease and of modalities, and it's just a matter of the needs rather than the age or the prognosis of the patient. All right, so to tell you a little bit about this program, which is a special and unique program, the Kidney Pal program, this is the group of people who were a part of it. We are the largest specialty team in the US devoted entirely to kidney palliative care. We had longitudinal inpatient and outpatient presence, and we were an interprofessional team, meaning there were 3 of us physicians. My 2 physician colleagues were in palliative care only, and I was the palliative care nephrology dual trained person. And we have 1 full-time nurse practitioner, 1 full-time social worker, both of whom were fellowship trained in palliative care. We worked at Brigham and Women's. We saw those numbers are actually out of date. We saw 1,300, almost 1,400 inpatients and 300 outpatients. Our clinic on the outpatient side had both in-person visits as well as the ability to do virtual. And we did get an educational grant from the Hearst Foundations a few years ago to support our patient advocacy and our education projects. I'll tell you a little bit more about how we use that grant money at the end. You know, we've solicited feedback to see how can we be most helpful to our nephrologists, our surgery colleagues, our internal medicine residents from everyone across the hospital system who we collaborated with. And these are some of the things we heard back. From clinicians, we heard that KidneyPal helped them have difficult conversations with patients, especially when I felt that non-dialysis care was the right option or better for the patient. They made care options transparent, did not dictate path. That's an important one. I will say half the time we're recommending dialysis because after a really in-depth goals of care conversation, it makes the most sense, even if it might not go very well. Feedback from families and patients have been amazing, just that one of them said they thought that conservative management helped people do the things they enjoy and have a different kind of quality of life, not just existing. And that's led to us getting some, international recognition from the medical community, in part for our policy and advocacy work around getting conservative management in payment models, getting it to be acknowledged as a legitimate home therapy when it's done properly and holistically and isn't just a euphemism for no dialysis. I'll talk about that more later. And we've done our best to publish what we've been doing. We, of course, have described KidneyPal itself in several papers. And then on the right, I'll just draw your attention to some populations that aren't commonly associated with palliative care, but absolutely can benefit from them. For example, transplant recipients who have failing allografts, who are approaching a decision whether they, if they can't get another transplant, are they going to go back on dialysis? Many of them are older and have suffered the consequences of immunosuppression already and are not always keen to resume dialysis, especially when they've been bit through it before. So those are people who have really intense shared decision-making needs. They often have a lot of symptoms, and we've done a lot of work to try to define those needs. And we did a mixed method study across the country, like asking transplant clinicians what their perceptions of the palliative care needs of their patients with failing allografts were. So case in point, just that there's a lot of aspects of KidneyPal care that have nothing to do with death or dying, and that have to do with a lot of patients across the spectrum, not just dialysis or end of life. So now I'm going to switch gears and talk specifically about conservative management as an alternative to dialysis, but I really want to emphasize that I view it as one small part of the iceberg that is KidneyPal care. We do a lot of support for patients who have chosen dialysis and who are struggling on dialysis, having symptoms, facing decisions about other things like amputations or TAVRs or surgeries. So everything I say next about conservative management is just one little piece of what I think of as the big KidneyPal care iceberg. Okay, so I think to start off, we all sort of operate on a false paradigm in a lot of the way that nephrology education and practice are depicted. And that's that for the largest group of incident kidney failure patients, which is most common in the population over 75 years old, the idea that there is just transplant, dialysis, or do nothing, give up, Grim Reaper, not sure, that's a false paradigm. I think the truth is that it's not as though dialysis gives a huge survival benefit anyway to older and seriously ill patients. If you look at this data from USRDS, the box on the bottom shows that the average life expectancy for patients who start dialysis in their 70s is about 3.5 years. In their 80s is 2.5 to 3 years. And that's significantly lower than how long they live in the general population. We have this way of talking about dialysis as though it's sort of like you live, it's either you don't do dialysis and you die, or you do dialysis and you live. And yes, of course, in certain ICU and inpatient settings, that may be true, but in the outpatient setting, it's definitely not true. And furthermore, survival benefit of dialysis is extremely limited in certain specific seriously ill patient populations. The box on the left showing that if you're living in a nursing home at the time at which you start dialysis, there's a huge study I'll go over in more detail showing that mortality is up to 60%. And initiating hospital dialysis when you're in the hospital for other complications is also extremely high. So we have to stop thinking about the treatment option paradigm as though dialysis means you live and no dialysis means you die. This is how I'd say I view the care options, and I think of these as the 3 pillars of options for people with chronic advanced kidney disease. Transplant, if you're lucky, again, among people over 75, they're often ineligible for transplant. Dialysis or conservative management. Problem is, what is conservative management anyway? It's kind of a black box. I'll go through a whole lecture and then people say, but what is it? Like, what do you really do? So I'll do my best to share that. I would say you all already know how to do conservative management because you all know how to give CKD care. And I'd say that at its simplest, conservative management is just really patient-centered CKD care. It's adjusting what we do for CKD based on not only the biochemical complications of what's happening for a patient, but also their goals and values. So maybe even more than usual, we would take into consideration that somebody's goal might be to have fewer medications and take, a consolidated amount of medications. And so you might focus on that in a CKD visit when you're giving conservative management versus more conventional blood pressure goals or acidosis goals, what have you. So it's not rocket science, it's CKD management with an extra emphasis on palliative skills. I spell those palliative skills out as following. I made this diagram just to represent it, that conservative kidney management, like I said, starting at the top at 12 o'clock here is simply medical care aimed at preserving kidney function and reducing or managing the metabolic complications of CKD like anemia and hypertension. Going around clockwise, advanced care planning customized to goals and values. That's important. When someone's made the choice not to do dialysis, it is important to speak with them and their family over time about what their wishes are for the future. We don't try to sugarcoat things or say, you're going to be fine. We say, well, most people over time do get gradually sicker. Here are the symptoms of progressive uremia. Here's what end of life often looks like. And here are the ways that we prepare you and your family to have control over the parts of that you can have control over. It sounds quite scary as a topic to broach the subject of, but oftentimes it's on these older and sicker patients' minds anyway, and they're really relieved to speak about it with a doctor. There's good evidence that few kidney patients feel that they have had those conversations with their nephrologist, so this is a big part of what we do in conservative management. Psychosocial support is another big part. Obviously, the emotions and existential and sometimes spiritual distress that come up when you think about being near to the end of your life can be pretty significant. And this is not really a strong suit within the primary palliative care skill set of every physician. It's mostly, can you find the support with your social work colleagues, your psychology colleagues, your chaplain colleagues, and having them join you for visits and conversations can be incredibly helpful. And lastly, symptom management. I'm going to talk more about this later, but this includes uremic symptoms as well as just the kinds of symptoms that happen a lot in this patient population, whether it's related to diabetes, musculoskeletal degenerative disorders, or what have you. Spending a lot of time every visit on asking about symptoms, intervening in ways to try to help them, whether it's pharmacologically or non-pharmacologically. It's a huge part of what we do in CKM. One other point. So as age increases, the risk of death actually exceeds the risk of developing a conventional indication for dialysis. So I'm talking about this patient population over 75, in part because many of them may not have goals or values that is best suited to dialysis. Many of them do, but plenty of them, when given all the information and the options, may say, I'd rather not do dialysis. And another huge subsect of this population will never progress to a conventional need to do dialysis. So, for example, if you're 85 and your GFR is 12, your chance of dying from any cause is significantly higher than your chance of developing a acidosis or hyperkalemia or volume overload specific to needing to start dialysis. So there are some people for whom, a choice to, generally speaking, plan on conservative management may also mean that they're taking their chances that they don't progress to a acute indication to start dialysis anyway, and that's not a bad wager to make if you're on the older side. All right, so what do we actually know about conservative management? What are the outcomes here in terms of survival, function, and symptoms? Well, survival with conservative care has been reported in observational studies over months to years. And on the whole, people live a lot longer than you expect them to. Of course, how long someone lives is highly dependent on how you measure that survival time. And so these studies are in no way sort of methodologically robust in that up until now, there has not been a randomized controlled trial of this. I would keep your eyes out if this is something that interests you, that there actually has been a huge randomized controlled trial completed in the UK over the last few months, and that data should be coming out shortly. They were able to basically argue that there is equipoise for older folks doing dialysis or conservative management, and they randomized people. So regardless, this is the data that we have. It's observational over the last 20 years. And as you can see from the key on the right, survival time depends a little bit on how you measure it. So the people in the yellow bar, or in the orange bar here all the way to the right, survival was measured from an eGFR of 10 or less. And on average, survival was 6 to 12 months. So that may surprise some people, that if you're living with a GFR of 8 and you choose not to do dialysis, on average, you may live 6 to 12 months. If your GFR is less than 15 when you start measuring it, which actually is, I'd say, the most common time when people are facing the decision of whether to get a fistula and prepare for dialysis, average survival is 1.5 to 2 years. So knowing that, and then thinking back to what we just looked at with the survival data from USRDS about how long people over the age of 80 live on dialysis, is we're really not comparing one therapy that gives you years and years and another which gives you, just time to die. It's actually pretty comparable in terms of 1.5 to 2 years may be what you get if you choose conservative management and your GFR is 15 or less. So this is the data we have on survival. I would say that it's not the most important data to most older people who are describing their goals of care and sorting out what to do. It's one piece of what's important to people, but independence and symptom burden is actually oftentimes a little more important to them. I want to emphasize that the survival estimates of months to years on conservative management really applies to people with CKD. This does not apply to your ICU patient, right? If you have an AKI in the ICU with a conventional indication to start dialysis, not starting dialysis in that patient, the prognosis is on the order of hours to days. Right? Let's not be confused about that. That, in my opinion, when you don't do dialysis for that patient, I call that you need to do end of life care. I think that's different from doing conservative management, which, like I said, has all this CKD management within it. You don't get a chance to do any of that with people who have AKI and for whom dialysis is not within their goals of care. Similarly, if you're already on dialysis and you stop dialysis, which, by the way, is the third most common reason for mortality among our dialysis patients, is semi-elective stopping of dialysis, usually due to worsening of clinical status. Most people, especially people who are anuric on dialysis, will live 7 to 10 days after that. So just let's be specific about what population we're talking about when we're talking about prognosis. And most people who choose dialysis, whether it's hemo or peritoneal, will live longer than people who choose conservative management. The question is, what do they do with that added time? This study, I think, shows in a visual format that a lot of the added time is spent doing dialysis related things, going to dialysis, handling dialysis, and sometimes being in the hospital for complications related to access or other parts of dialysis treatment. So you show this to a patient, and sometimes it's like a litmus test. Some people will say, well, I might live almost double if I do dialysis. I'm definitely want to do dialysis. And others might say, well, if it's double, but a lot of the time is spent in a medicalized way, I'd rather sort of spend the time I have at home and not be in the hospital as much. So it can be a helpful thing to develop your language around prognosis other than just time, but also what does the time look like? What about function? So when you compare conservative care and dialysis with functional status, there is some data showing that conservative management preserves your functional status around 60 if it's a Kornofsky score, which needs some assistance but is mostly independent, up until the last month of life, after which there's a very steep drop off, during which uremic symptoms get severe and most people become bedbound and less responsive. When you compare that to functional trajectories for patients who are already older or sicker who start dialysis, it's actually better on conservative management. This is a huge study from the New England Journal in 2009, in which they looked at functional status and mortality of nursing home residents within 1 year of starting dialysis. And the vast majority had decreased their functional status, and then more than 50% had died within the first year. So although we often think maybe in the hospital, this older person, they're swollen, they're encephalopathic, maybe dialysis will get them back on their feet. They'll be able to do physical therapy. If they already came from a debilitated state and requiring assistance in a nursing home, the chances of them regaining or improving their functional status above baseline is relatively low. So lastly, symptoms. This is an important piece of decision making for patients considering, should I do dialysis? Should I try conservative management? What I tell people is that symptoms are really common in kidney failure, whether you treat it with dialysis or not. Which symptoms are more prevalent is what varies, but not the amount of symptoms or sort of the day-to-day experience of your body feeling like it's living with an illness. So fatigue is incredibly common in both, whether you do conservative management or dialysis. Things like muscle cramping and anxiety and insomnia tend to be higher in dialysis patients, understandably for what they go through with ultrafiltration, and many people experience that anxiety and insomnia related to treatment. And then things like itch and nausea and shortness of breath are more common in conservative management patients. We aim to manage those symptoms with medications, but I do tell people up front there are some symptoms that we're not going to be able to take away, like fatigue. I will say with really high quality conservative care, meaning when you're actually asking about symptoms and trying to intervene on them, symptoms are shown to decrease over time. There's data from the group in Australia where I did part of my training to learn how to do this, that all symptoms and overall quality of life gets better over time with active conservative care. Two really common symptoms I'm highlighting here. One is uremic pruritus and the other is dysgeusia or taste changes. I think people feel kind of like sometimes clinicians can feel nihilistic about these symptoms, like it's just part of uremia or it's just the hyperparathyroidism. And that may be true, that it is in some ways hard to completely eliminate, but there are a lot of things one can do. This is a treatment algorithm ladder that I developed with some partners, showing that things like extremely low dose gabapentin at night, if itch is your main concern, can be miraculous. It can almost sound homeopathic because the dose is so low compared to what we use for diabetic neuropathy. But 100 milligrams at night can really help people sleep and stop itching so much. I've also seen it be able to delay the need to start dialysis for months. If itch, for example, is the main reason that you feel like you need to pull the trigger and start dialysis. On the right here, this taste plate is a cute thing you can give to patients, just showing that depending on what part of their taste is deranged, you can do different interventions. If they have mostly blandness, which is the most common taste derangement in uremia, advice on taking zinc and how to spice up their food can help them eat and can actually reduce their chance of developing frailty from eating less than they need. Okay, moving along, how do we recommend or offer conservative care? So I can't really explain this in a short period of time, but am going to point you toward resources that can help. It's a complicated, usually iterative conversation about goals and shared decision making. I'll say this, that the New York Times is on to us that unfortunately conservative management is often not even mentioned in many conversations about treatment options for advanced kidney disease. Most people feel they were never given the choice about dialysis, and when they hear it, some people won't want to do it, but almost everyone is happy that they heard the option. The longer I work in this, the longer I think of new ways to define this, but I think we have a little bit of a language problem when it comes to our field, which is that we often mistake or we replace the therapy for the illness. So if we're in the hospital talking to someone coming in with an AKI, it's very common for us to say what we're thinking, which is we're worried you might need dialysis. Would you want dialysis? When actually, I think the more neutral and accurate thing to say, and to really catch yourself and make sure you say you're talking about the illness and not the treatment before the illness, is you might develop kidney failure, and we're going to need to talk about your treatment options for kidney failure. I think this leaves room for the option of conservative management or non-dialytic management in a way that if you start talking about it, like you might need dialysis, and then actually when it comes down to it, you don't even think they should do dialysis, say they have advanced cancer or advanced cirrhosis, when you start by saying you might need dialysis, and then you later say, I don't think we should do dialysis, it's confusing for patients. So start by saying you might develop kidney failure. I want to speak with you and your loved ones about what the options look like and what they mean for your day-to-day life. Shared decision making is complicated, and I would just say that it's supposed to be a meeting of two experts. We're the experts on the medical estimates, and the patient's the experts on what matters to them and some of how they want to talk about this stuff. And it's hard. I think it takes more than one conversation, and it takes a lot of curiosity and sort of listening. But to practice it, I think we don't get a whole lot of direct training about it. We get a lot of practice because it's really common in your jobs as nephrologists, but nephrology fellows get extremely little training in communication, especially around things like determining when to refer to palliative care or how to tell somebody they have a poor prognosis and you don't think they would do well on dialysis. There are some good resources that I want to spend some time telling you about so that you can check them out if you are interested. NephroTalk is a 3-day communication skills workshop led by Jane Schell that focused on helping people deliver bad news in a skillful way. The bad news being you have kidney failure, we need to talk about your treatment options, and then in that context, explore people's goals of care and make a treatment recommendation that aligns with the patient's goals. After this program, fellows became better communicators. They became more efficient, and that means that it was actually faster for them to have these conversations, not just they spent forever, going through goals of care. I want to really focus on some cool interactive curricula that you can access right now if you're interested. My team and I that I showed you in the beginning of the talk created this conservative management curriculum that's 3 basic modules where the first one is how do I do it? What do I do with the CKD? What do I do with the anemia? What do I do with the potassium binders? The second module is more symptom focused. What do I do for this neuropathy? How do I get their restless legs to go away? And then the last one is care transitions near end of life. What about when they're getting really sick? And what if they, need hospice? Or what if they question their decision not to do dialysis? It's supposed to be practical, interactive, gamified content that helps you learn how to do this stuff. It's also got some stuff about diet because that's one of the most common interests of patients on conservative management is how do I manage my diet in a way that can help me live as long as possible with at least complications. So this is the, you can use this QR code or this website to access it. It's completely free. You just have to register with your email. But if you do it and you find it useful, please let me know. There's some embedded survey feedback in there. I also just today found this very cool chatbot on the website ePrognosis. It's part of UCSF's ePrognosis resources, but they just started this new thing where you can actually practice giving bad news or sharing your worries about somebody's prognosis with this chatbot. So I did it and it wasn't bad. It's certainly not as stressful as when you're with a person in front of you, but it's not a bad way to practice if you want to do so in the privacy of your own computer. All right, lastly, how many patients change their mind? So that's a question I get a lot. Like, that sounds great, conservative management, sure, but when I really need it, I'll do dialysis. Like, don't people show up in the emergency room vomiting and saying, okay, they want to try dialysis? Well, no, not really. This is one of the earliest studies from Sydney looking at their conservatively managed patient population. And in their study, fewer than 2% of patients who had chosen conservative management changed their mind and started dialysis. So first of all, I don't think it's a failure if someone changes their mind and tries dialysis. I think it's only a failure if they do so because they weren't prepared or didn't understand what their prognosis would look like with conservative management and who their support team would be, who to call if they started feeling unwell. I think with a really robust, proactive approach to conservative management, in our practice as well, very few people change their mind at the last minute. So my take-home messages here, first of all, I think kidney palliative care can enhance quality of life through symptom management and decision-making support. And conservative management is a whole lot more than just not doing dialysis. It can be a robust and proactive holistic care option that might optimally suit certain patients' goals and preferences. So with that, those are my references, and I will look forward to your questions in a little bit.